Imagine taking your 12-year-old daughter to the local clinic
Right.
because she's just constantly exhausted.
Right. A very common complaint.
Yeah, exactly. So her blood test shows low hemoglobin, and the computer protocol just flashes, anemia. So the clinic puts her on iron tablets,
Following the standard operating procedure.
strictly following it, and you trust the system. So for 2 full years, you keep going back. She keeps getting more tired, and they keep handing you iron pills.
2 years is a really long time to just keep prescribing the same thing.
It's wild. Then, one day, she has severe abdominal pain. A different doctor finally does something groundbreaking. He actually touches her stomach.
A physical examination.
Yeah. And he feels a massive, unmissable lump.
Yep.
That anemia, it wasn't just a lack of iron. It was a huge kidney tumor that had been growing undetected for 24 months.
While medical professionals just stared at a computer screen.
Exactly. Instead of the child in front of them. So, welcome to the deep dive. Today, we're asking a pretty terrifying question for you listening at home. What happens when the medical checklist completely replaces the human eye?
It's a chilling scenario, and tragically, it's not an isolated incident at all. Today, we are unpacking a really detailed, deeply concerning stack of medical evidence.
Yeah, it's heavy stuff today.
It is. We're looking at 2 complex infograms titled, "When Algorithms Replace the Clinical Eye," along with a whole dossier of severe clinical case notes.
And these were compiled by a specific doctor, right?
Yes, meticulously compiled and submitted to the UK's General Medical Council, the Royal Colleges, the World Medical Association, and the Surrey Primary Care Trust by a physician named Dr. Srivatsa.
And what we're doing for you today is, well, dissecting a profound shift in how medicine operates. Because, you might naturally think that standardizing healthcare would make it safer,
That's the assumption, yeah.
like giving nurses and junior doctors strict flowcharts to follow. We use checklists to keep airplanes from falling out of the sky, right?
Right, the aviation model.
Exactly. So why wouldn't we use them to stop medical errors? But the sources we're looking at today suggest the exact opposite is happening.
And to frame this properly, we need to clarify this is not an attack on the individuals working on the front lines.
No, not at all.
The nurses, the pharmacists, junior doctors, they are under immense pressure. What the sources are critiquing is a systemic issue. It's called tick box medicine.
Tick box medicine.
Yeah, it's an institutional architecture that actively forces staff to rely on pre-printed algorithms and symptom-checking software.
Instead of trusting their own judgment.
Exactly. Or worse, it empowers them to make diagnoses far beyond their actual medical training.
Okay, let's start by getting a sense of the sheer gravity of this.
Yeah.
Before we get into the biological mechanics of these hardcore cases, and they are hardcore, we need to understand the macro burden. Just how much damage is this tick box medicine doing globally?
The statistics in the source material are, well, they're staggering. In the U.S. alone, diagnostic errors cost the economy an estimated $750 billion annually.
Wait, $750 billion with a B.
With a B. But the human cost is the real tragedy here. Recent estimates show over 1 million people a year are harmed by diagnostic errors in the U.S.
That's horrifying.
And patient deaths directly linked to these misdiagnoses. They're estimated to be between 40,000 and 80,000 per year.
Oh my God.
Some researchers even suggest up to 400,000 patients die every year from preventable issues in hospitals. It makes medical error a leading cause of death.
So we're talking about hundreds of thousands of lives. And this isn't just isolated to the U.S., right? The sources explicitly highlight the U.K., which is where Dr. Srivatsa's clinic was.
Right. Globally, about 16% of all preventable patient harm is related to diagnostic errors.
Yeah.
But when we zoom in on UK primary care...
Things like the walk-in clinics.
Exactly, the general practitioners, the first point of contact. The figures there are alarming. Diagnostic errors account for over 60% of all patient harm in that setting.
Over 60%. That means if you're harmed in primary care, more than half the time, the initial diagnosis was just fundamentally wrong.
It's a massive systemic failure.
But okay, I want to push back on this a little, or at least try to understand the logic. Over the last few decades, there's been this push for task shifting.
Yes, allowing nurses or pharmacists to diagnose using strict criteria.
Right. And I kind of get it. Like if my internet goes down, I want the IT guy reading from a strict troubleshooting script. Is the router on? Are the lights green? It makes sure nothing gets missed. So why doesn't that logic translate to the human body?
That is the pivotal question. An IT flowchart works because a router is a closed binary system. Humans designed it.
Right. It only has so many states.
Exactly. But the human body is an open, infinitely complex biological system. To understand where algorithms fail, we have to look at where they actually succeed.
Okay, where do they succeed?
If you are a patient in an intensive care unit, an ICU algorithms are incredibly effective.
Wait, but I thought ICUs ran entirely on monitors and protocols. Why do algorithms work for a guy on life support, but fail for someone walking into a clinic with a rash?
Because in an ICU, the environment is entirely controlled. The data is highly specific and continuous. You have real-time telemetry.
Like heart rate and oxygen levels.
Yes, arterial pressure, all
Yeah.
of it. The algorithms there use clear binary cutoff points. If the mean arterial pressure drops below 65 millimeters of mercury, the protocol says administer vasopressors.
So the diagnosis is already figured out.
Precisely. You know they're in shock. The algorithm is just managing the physiological parameters.
It's managing a known crisis based on hard numbers.
Right. But primary care, that's the Wild West of medicine.
Yeah, people just walking in off the street.
Exactly.
Yeah.
A patient walks in with a vague complaint like, I just feel off or my stomach hurts. Primary care relies heavily on sensitivity versus specificity.
What does that mean in this context?
An algorithm for a walk-in clinic is usually highly sensitive. It wants to catch every possible common illness. But it lacks specificity. It flattens three-dimensional biological complexity into a two-dimensional spreadsheet.
So it's just asking yes or no questions?
Right. It
Okay.
asks, do you have stomach pain? Yes. Are you a young female? Yes. And then it funnels you down a highly probable but narrow diagnostic pathway.
And completely strips away the actual conversation and physical cues.
Exactly. The human intuition a doctor uses to realize something is terribly wrong is just gone.
Okay, so missing a hidden tumor, because you only look at a blood test, is one thing. But what happens when the physical signs of a disease are literally right there and the algorithm still blinds them?
It happens more often than you'd think.
Let's dive into the cases from Infogram 1 and Dr. Srivatsa's notes. Let's revisit that horrific first case I mentioned in the intro, the missed mass.
This case is the quintessential example of algorithmic blindness. So we have this 12-year-old girl presenting with tiredness.
And a routine blood test shows low hemoglobin. Now, for anyone listening who isn't a doctor, hemoglobin carries oxygen in your red blood cells. Low hemoglobin means anemia.
Right, so the computer sees the low number and says, treat for anemia.
And this is where the biological mechanism of the failure is crucial, right? Because anemia isn't a disease itself.
No, it's a symptom. It's a physiological red flag that something else is disrupting the body. It could be a nutritional deficiency, sure.
Which is what they assumed.
Exactly. But it could also be an autoimmune disorder, internal bleeding, or, as in this tragic case, a malignancy.
A tumor.
Yes. Tumors, especially kidney tumors like Wilms tumor or renal cell carcinoma, they cause severe anemia,
How do they do that?
either by bleeding internally or by disrupting the kidney's production of erythropoietin. That's the hormone that tells your bone marrow to make red blood cells.
Oh, wow. But the algorithm didn't prompt anyone to look for a tumor. It just said anemia equals iron pills.
Yes. For 2 years.
2 whole years without a single clinician taking 10 seconds to ask her to lie flat so they can palpate her abdomen.
When Dr. Srivatsa finally saw her at age 14 for acute abdominal pain, he just touched her stomach and felt the massive mass.
And she lost her kidney because of that delay, right?
She lost her kidney, and the renal damage left her with chronic high blood pressure for the rest of her life.
The girl's father actually confronted Dr. Srivatsa and asked, "Why didn't anyone just examine my child?" And in his notes, Dr. Srivatsa wrote, he had no answer for him. It's indefensible.
It really is.
But man, it gets even darker when we look at case 4, the overlooked trauma. Because if the first case was a failure of physical omission, this one is a catastrophic psychological omission.
This is an incredibly sensitive case.
Yeah.
But it's absolutely vital for understanding the dangers of non-clinical triage.
Yeah.
A 12-year-old girl was brought to the clinic with a fresh blood stain in her underwear. She was seen twice, first by a nurse, then by a doctor.
And they were operating entirely on a symptom-only protocol.
Exactly. They entered her presentation into the computer. The algorithm recognizes blood in a female patient's pelvic region and directs them down the most statistically common pathway.
A urinary tract infection.
Yes, but they diagnosed a UTI without ever examining her.
And her urine tests came back completely normal.
They completely ignored the negative lab results because the protocol gave them an answer they were comfortable with.
Which means they completely missed the horrific reality that this child was a victim of sexual abuse.
Yes, they missed traumatic pelvic injuries.
I just want to pause here because this is so heavy. Imagine the betrayal of trust there. You go to a medical facility for help, and the checklist completely blinds the staff to physical trauma.
It's a systemic failure to protect the most vulnerable.
How does a trained professional look at a bleeding child, see a negative urine test, and still just shrug and say, it's a UTI?
It introduces a psychological mechanism Dr. Srivatsa explicitly highlights. Your eyes don't see what your mind can't think. We can call it cognitive outsourcing. When a practitioner is forced to rely on a protocol, their critical thinking is outsourced to the algorithm.
So the protocol says blood in this demographic equals infection. And their brain just literally stops generating alternative hypotheses.
Exactly. They don't consider trauma. They don't consider abuse. The algorithm provides this false sense of certainty that overrides their clinical intuition.
Cognitive outsourcing. That is terrifying. I'm sure you, listening to this, can think of times at your own job where you were so focused on following a standard procedure that you missed an obvious problem right in front of you.
It happens in every industry.
But when it happens in a walk-in clinic, the stakes are life and death, which naturally leads us to a concept heavily emphasized in the second infogram, the illusion of competence.
Yes, checklists don't just make people miss things. They make people feel immensely capable while they're missing things.
Giving someone a highly detailed form to fill out makes them feel like a doctor, even if they don't have the training. Let's look at case 3. The shingles illusion.
This one perfectly illustrates the danger of triage systems without physician oversight. We have a 20-year-old man who goes to a walk-in clinic with a rash on his neck.
And using a digital symptom checker, he's diagnosed with shingles and sent home. Now, shingles is a viral infection, right? The reactivation of the chickenpox virus.
Correct. It causes a painful, blistering rash. But a week later, this young man returns. He looks somewhat stable, but he's demanding an emergency appointment, saying he feels incredibly unwell.
And the receptionist can't offer him a standard slot.
Right, but instead of turning him away, she uses a color-coded triage card, the Maya card.
Which Dr. Srivatsa actually invented. We'll talk about the mechanics of that later.
Exactly. So she asks him about 3 specific symptom categories, and his answers trigger 3 red flags. Recognizing the danger, she bypasses the computer queue entirely and rushes him to Dr. Srivatsa.
And what does he find when he actually looks at the patient? It wasn't shingles at all.
No. It was a staphylococcus infection in pedigo that had been untreated for a week and progressed into life-threatening septic shock.
Let's break down the biology of how the algorithm failed here. The digital checker asks, is there a rash? Yes. Is it painful? Yes. Localized?
Yes.
The algorithm spits out shingles because it's common, but it lacks the visual fidelity to ask, is the rash forming honey-colored, crusty lesions typical of a bacterial staph infection?
Right. An algorithm flattens biological reality.
A trained clinical eye looks at the characteristics of the lesions, the distribution, the patient's pallor.
And because it was misdiagnosed as a virus, he wasn't given antibiotics. The bacteria multiplied, entered his bloodstream, and triggered septic shock. Can you explain what septic shock actually does to the body?
Septic shock is an extreme systemic inflammatory response. The immune system overreacts to the infection, causing massive vasodilation.
Meaning the blood vessels widen.
Yes, they widen so much that blood pressure plummets. Organs stop receiving oxygen and begin to fail. It is a catastrophic medical emergency. And the symptom checker created an illusion of competence for the initial clinic staff. They kicked the boxes, the computer said shingles, and they felt confident in a diagnosis that almost killed him.
If that receptionist hadn't used the May card to spot the red flags, he likely would have died.
And speaking of the lethal intersection of algorithmic confidence and a fatal lack of medical knowledge, case 2, the Bonjela error. When I read this in the source notes, my jaw literally dropped.
It is arguably one of the most alarming cases in the entire dossier. It involves a terminally ill, immunosuppressed patient who developed a condition known as DIC.
Disseminated intravascular coagulation. What exactly is happening in the body when someone goes into DIC?
DIC is a paradoxical and terrifying physiological state. It's often called a consumption coagulopathy. Essentially, a severe underlying trigger like sepsis or advanced cancer causes the proteins that control blood clotting to become hyperactive.
Okay, so they start clotting too much.
Yes, the patient begins forming thousands of microscopic blood clots all over their body. These microclots block small blood vessels, damaging organs. Oh, man.
But simultaneously, because the body is creating so many clots, it completely uses up all of its clotting factors and platelets.
Wait, so they run out of the very materials needed to stop bleeding.
Exactly. Once the clotting factors are depleted, the patient begins hemorrhaging uncontrollably from everywhere. 4D sites, their gums, their GI tract.
They're clotting and bleeding to death at the same time.
It requires incredibly complex, immediate critical care intervention.
And in this case, the patient is at home, severely unwell, unable to even swallow water. An attending nurse practitioner visits her. The nurse sees the patient bleeding, likely from the mouth or gums.
Yes.
And what does this nurse, operating under a clinical protocol, prescribe for a patient in the middle of a lethal coagulation cascade?
Bonjela.
Bonjela, teething gel.
She prescribed over-the-counter teething gel for systemic organ failure. But the horror deepens. She also reassured the frantic family that the patient's recent blood tests were normal.
Unbelievable. When Dr. Srivatsa later reviewed this event and spoke to the nurse, he made a chilling discovery. She did not possess the medical training to even know what the acronym DIC stood for.
She literally asked him, "What do you mean by DIC?" I just want you, the listener, to absorb that for a second. How is it possible that a healthcare system allows someone to operate independently, visiting terminally ill patients, when they don't even know the name of the lethal complication their patient is dying from?
This exposes the core systemic rot of tick box medicine. The primary care trust had empowered this nurse to work essentially as a doctor.
But without the training.
Exactly. She didn't have the 5 to 7 years of rigorous medical school physiology and pathology. The protocol gave her a script, but not the knowledge to understand when the script was failing.
The sources refer to this specific danger as pre-printed thinking. There's a fascinating paper reference about the danger of pre-printed assessment sheets.
Yes, when junior doctors or nurses are just filling in blanks on a form, they are focused on the paper or the iPad screen instead of the human being in the room.
The author notes that with a pre-printed history sheet, there is almost no eye contact.
And we must emphasize, eye contact is vital clinical data. Assessing a patient's pallor, noticing if their breathing is labored.
Or picking up on the scent of ketones on their breath.
Yes. Or the slight yellowing of their sclera. All of that ambient data collection happens while a doctor is taking a history. If you are just trying to get through a list of questions, you aren't diagnosing. You are administering a multiple choice test.
We are training a generation of healthcare workers to be data entry clerks. Dr. Srivatsa's colleague noted that staff are taught to fill in the blanks meticulously, but are unable to collect and analyze data in their brain.
And this leads to insane errors.
Like the 24-year-old with jaundice. The notes mention a patient presenting with yellowing of the skin and eyes and pale stools.
Yes. And the attending nurse diagnosed paracetamol abuse and actually advised the patient to go home and take more paracetamol.
Which is incredibly hepatotoxic. Taking paracetamol for liver failure is like throwing gasoline on a fire.
The correct diagnosis was viral hepatitis. But because the checklist likely associated jaundice in a young person with drug or alcohol abuse, the nurse followed that algorithmic branch blindly.
Missing the infectious disease entirely and actively prescribing a poison to a failing liver. It's terrifying.
It really is.
But missing a hidden liver infection is one thing. What about when the physical signs of a disease are literally painted on a patient's face? Let's talk about the cost of missing the physical exam, specifically the 23-year-old medical student.
This case is a masterclass in the necessity of the clinical eye. A 23-year-old medical student comes in, very anxious about some spots on her face.
And previous nurses had seen her, but they focused entirely on her complaint about a husky, deep voice. They actually referred her to a speech therapist.
Right. But Dr. Srivatsa notes that the moment she walked into his office, before she even spoke, he noticed she was shaking, highly anxious, and presenting with this unusually deep, masculine voice.
He didn't just hear the voice and think, throat problem.
No, he synthesized the anxiety, the spots, and the vocal changes, and immediately suspected a systemic endocrine or thyroid issue.
The endocrine system regulates hormones, right?
Exactly. To confirm his suspicion, he requested that she undress behind a screen so he could properly examine her chest and body.
And what he found was extreme hirsutism. Excessive, thick hair growth on her chest, cheeks, and legs, which she admitted she'd been secretly shaving.
He recognized this immediately as a severe hormonal imbalance and referred her to an endocrinology specialist. He caught what the protocol missed.
But here's the shocking irony. The patient actually filed a formal complaint against Dr. Srivatsa for making her undress.
She felt uncomfortable because she had been conditioned by the protocol-driven clinic to believe that a thorough medical examination didn't require actually looking at the body.
She stated she had been examined numerous times at that surgery by other staff with all her clothes on.
Because nobody had ever bothered to look at her chest or legs. They completely missed the glaring physical signs of her hormonal disease, delaying her care and absurdly sending her to a speech therapist.
And the ultimate proof of institutional failure. The primary care nurse assigned to investigate Dr. Srivatsa, based on this complaint, didn't even know what the medical term hirsutism meant.
It's astounding. The investigator didn't even know the pathology she was investigating.
You cannot make this up.
Yeah.
But as infuriating as that administrative incompetence is, the next case in the notes is genuinely heartbreaking. Let's talk about the 3-month-old baby and the battle between a milk allergy and craniostenosis.
A 3-month-old infant was brought to Dr. Srivatsa with a history of severe vomiting, a rash, and excessive, inconsolable crying.
Now, algorithmically, an infant with vomiting and crying is almost always triaged down a gastrointestinal pathway.
The checklist suggests feeding issues or reflux.
But Dr. Srivatsa didn't just ask the parents questions. He physically examined the baby. He looked at the child's head, noticed it seemed unusually small, and palpated the skull. He realized the sutures were closed.
For context, a newborn skull is not a solid bone. It is made of several plates, separated by fibrous joints called sutures and soft spots called fontanelles.
To let the brain grow, right?
Yes, they must remain open and flexible to allow the rapidly growing brain to expand. But in this baby, they had fused prematurely.
A condition called craniostenosis.
Yes. Because the skull cannot expand, the growing brain is trapped. It is put under immense, crushing intracranial pressure, which causes severe neurological symptoms like projectile vomiting and extreme irritability.
And it requires immediate surgical intervention to open the skull.
Dr. Srivatsa realized this instantly and referred the child to the hospital specialists.
But the hospital consultants projected his referral. They stuck to their algorithm. They looked at a vomiting baby and decided it was a milk allergy.
They treated this child with various alternative milk formulas for months.
And the parents, assuming the hospital consultants knew best, didn't return to the GP. 6 to 8 months later, they finally bring the child back to Dr. Srivatsa, and he is horrified.
He described the poor child in his notes as looking like a toad with eyes popping out of his skull.
Oh my God.
The intracranial pressure had become so severe it was physically forcing the child's eyes outward.
The infant was eventually seen by a pediatric neurologist at Great Ormond Street Hospital who happened to notice the child during ward rounds.
The neurologist immediately diagnosed the craniostenosis and rushed the baby into surgery.
But the delay months of treating a fused, pressurized skull as a simple milk allergy because of rigid adherence to a standard protocol, it left that child with permanent, severe neurological disabilities.
This poses such a critical question about the systems we build. Think about it logically. If a protocol dictates a specific pathway, like vomiting equals milk allergy, how does a practitioner justify stepping off that path?
Yeah, if a nurse or a junior doctor sees something weird, but the computer says do X, what happens if they trust their gut and do Y?
You've hit on the invisible force driving this crisis. The rigid system actively punishes the application of actual clinical knowledge. It has created an architecture of defensive medicine.
Meaning you just cover yourself legally.
Exactly. If you follow the protocol to the letter and the patient dies, the system protects you. The institution can say, we adhered to the guidelines.
But if you deviate because your clinical eye spot's an anomaly and something goes wrong, you are entirely on your own.
You will be castigated by the administration and likely sued. The safest thing for a junior doctor to do is to turn off their brain and follow the flowchart.
Which perfectly transitions us into the administrative fallout of all this. Because Dr. Srivatsa didn't just quietly compile these cases, he tried to blow the fire alarm.
Indeed. From 2003 to 2006, he meticulously gathered over 70 similar cases, demonstrating how this nurse-led, protocol-heavy system was inflicting massive pain and suffering.
Quackery, as he called it.
Yes. He took this mountain of evidence to the General Medical Council, the Primary Care Trust, and the Royal Colleges. He was trying to protect patients from a system that had lost its primary function of care.
But to be fair to the administration, and to play devil's advocate for a second, if a doctor is digging through patient files of people he isn't actively treating to compile this dossier, isn't that a privacy violation? how do you balance whistleblowing with data protection rules?
That is exactly the weapon the institution used against him. The source texts reveal a deeply entrenched conspiracy of silence.
So instead of addressing the horrific diagnostic errors, the missed tumors, the undiagnosed craniostenosis, the institutions move to protect the system.
They accuse Dr. Srivatsa of breaching Caldecott principles.
For those unaware, Caldecott principles are the UK's strict guidelines governing the sharing of patient info, kind of like a CHAPA in the States.
Right. They essentially accused him of violating patient confidentiality just for reviewing the clinical notes of patients who had been misdiagnosed by others in his own shared practice.
Using privacy laws as a shield to suppress evidence of gross negligence.
Exactly. He faced intense victimization, and they eventually removed him from the performers group list, crippling his ability to practice medicine.
And the sources mention that junior doctors witnessed this retaliation and are terrified to whistleblow.
Meh.
It's like firing the guy who pulled the fire alarm because you don't like the noise while the entire building burns down.
It's exactly like that.
But this tension between medical error and accountability leads to a complex legal debate presented in the sources. The criminalization of medical errors. There is a landmark Indian Supreme Court case referenced heavily in the notes, Jacob Matthew v. State of Punjab.
Yes.
Why is an Indian legal case relevant to a UK primary care crisis?
Because the Jacob Matthew case sets a vital global precedent for differentiating between a tragic but normal medical error and gross criminal negligence.
Okay, how so?
The case deals heavily with Section 304A of the Indian Penal Code, causing death by negligence. When patients suffer from these algorithmic misdiagnoses, their families naturally demand justice. They want to see someone punished.
Which is completely understandable. If your 12-year-old loses a kidney because nobody touched her stomach for 2 years, you want heads to roll.
Absolutely. However, the legal and ethical consensus, as argued in the Jacob Matthew ruling, is that criminalizing normal medical errors is highly destructive to public health.
Because it leads to defensive medicine again.
Exactly. If every misdiagnosis leads to a police investigation, doctors order unnecessary, expensive, and invasive CT scans for every minor headache just to cover themselves. They refuse to treat high-risk patients. It bankrupts the healthcare system.
But, and this is a massive but, the cases we are talking about today aren't normal errors of judgment, are they?
They are not. The argument presented in Dr. Srivatsa's sources is that these specific algorithmic failures cross the line into gross negligence.
Because they completely skipped a physical exam.
Precisely. The foundational duty of care was intentionally abandoned. If a doctor thoroughly examines a patient, runs tests, and still makes an incorrect call, that is human fallibility.
But refusing to physically examine a child for 2 years while prescribing iron tablets simply because a computer protocol didn't prompt you to is a systemic failure of duty.
The institution is essentially mandating negligence.
So how do institutions justify protecting a protocol over protecting a patient?
Through the cold lens of standardization, efficiency, and auditability, a protocol is measurable. It can be easily tracked on a spreadsheet.
And it lets them use cheaper, less trained staff.
Yes. A brilliant clinical catch by an experienced doctor is messy, unpredictable, and expensive. Bureaucracies crave predictability, even if that predictability occasionally results in predictable harm.
Which brings us to a really crucial pivot, because it is easy to sit here and complain about a broken system. But Dr. Srivatsa isn't just a critic, he is an inventor.
He has a demonstrated history of practical, structural problem solving. The sources highlight that back in 1992, he identified that intravenous cannulas were a major source of spreading MRSA superbugs in hospitals.
IV drips, right.
Yes. And he didn't just write an academic paper complaining about it. He actually invented a spring-loaded device with a needle-protecting guard to mechanically solve the problem.
Even though major manufacturers actively tried to stifle his invention to protect their own patents, the guy is a bulldog for patient safety. So he takes that same inventive mindset to the checklist trap.
If algorithms are blinding people, how do we fix it without throwing out the concept of triage entirely? Enter the Dr. Maya tool.
The Dr. Maya approach, detailed in the second infogram, it's a fascinating counterproposal to the digital symptom checker.
It recognizes reality. We cannot get rid of triage. Walk-in clinics are overwhelmed, staff have to prioritize patients, but the fundamental flaw of current algorithms is that they try to spit out a definitive medical diagnosis.
Like telling the receptionist, this patient has shingles.
Exactly. The Dr. Maya tool strips that away. It is designed purely to differentiate well from unwell.
It uses a color-coded system, right? Red, yellow, green, How does it fundamentally differ from the algorithms that are failing?
It relies on broad pattern recognition rather than diagnostic commitment. Instead of a branching tree of yes-no questions to arrive at a specific disease, the Maya card trains frontline staff to recognize physiological thresholds.
Like vital signs and broad symptoms.
Yes, severe pain, altered mental state, abnormal breathing. If a patient hits a threshold, they are flagged as RD. It doesn't ask the receptionist to practice medicine or guess the disease.
It simply gives them a highly sensitive tool to recognize when a patient's biological presentation is throwing up red flags, just like the receptionist in the septic shock case.
Exactly. The computer said shingles, but the receptionist used the physical May card, saw 3 red symptoms, and bypassed the algorithmic cue to get him to a doctor.
She saved his life because the tool allowed her to act on the severity of the symptoms rather than a false diagnosis.
The Dr. Maya tool bridges the gap. It empowers frontline staff to quickly identify serious systemic illness and immediately route those patients to a trained physician.
It stops the patient from getting trapped in an endless loop of diagnostic flowcharts administered by staff who don't have the physiological training to recognize when the flowchart is wrong.
It restores clinical autonomy.
It gives the staff permission to say, hey, this biology looks complicated and dangerous. Let's get human eyes on it immediately. So the goal isn't to smash the computers or ban checklists entirely.
Not at all.
The goal is to use tools to enhance the clinical eye, not completely blindfold it. We need tools that raise the alarm, not tools that try to put out the fire themselves.
That is a perfect synthesis of the evidence. Guidelines and protocols are excellent guardrails. They keep the vehicle from driving off the cliff, but they make terrible drivers.
You still need a trained human holding the steering wheel.
Looking at the road ahead, anticipating the unique, unpredictable conditions of that specific patient's biological journey.
And that brings us to our final takeaway. Speaking directly to you, the listener. The key insight we've extracted from this massive stack of sources, from the statistics of global harm to the tragic stories of missed tumors and ignored trauma, is that medicine is fundamentally a human endeavor.
It has to be.
When a healthcare system prioritizes tick-box compliance, when it values a perfectly filled-out digital form over a doctor actually looking at, touching, and listening to the patient, the results are catastrophic.
The physical examination is not just a quaint medical tradition. It is the most vital, high-fidelity data collection tool in existence. Abandoning it for the false certainty of a flowchart is a dangerous, systemic failure.
Which leaves us with a deeply provocative thought to end on today. We've spent this entire time talking about relatively simple algorithms, decision trees, flowcharts, multiple choice symptom checkers.
Right.
But we are currently racing at breakneck speed toward an era of advanced generative AI in healthcare.
Indeed. One of our sources explicitly discusses a new conceptual framework for AI-supported shared decision-making in acute stroke care.
Using natural language processing and complex LLMs.
Yes, to generate predictions and treatment pathways based on immense, incomprehensible data sets.
So here is the question you need to mull over as you go about your day. If our current, relatively simple, human programmable checklists are already blinding practitioners to obvious physical symptoms, like a 14-year-old with a massive abdominal tumor, or a patient bleeding to death being handed teething gel, what happens when we hand over the diagnostic keys to an incredibly complex, opaque AI black box?
It's a terrifying prospect.
Will the illusion of competence become so overwhelming that we permanently lose the clinical eye? Or is the tragic evidence we've reviewed today the exact wake-up call we need to ensure that human beings, with all their messy intuition and physical senses, remain firmly, undeniably in the loop?
When you step into the muddy waters of human disease, you don't want a computer telling you what the water should look like based on a statistical average. You want a trained professional who knows how to swim.
The algorithm is just a map. We still have to look at the territory. Catch you on the next deep dive.